Thank you for joining us today and for the opportunity to present to this group. We're excited to share with you our work on advancing pediatric emergency care in low-resource settings, focusing on two distinct but connected projects in Nepal and Botswana. My name is Morgan Bowling, and I'm faculty in the Departments of Emergency Medicine, Pediatrics, and Global Health at the Icahn School of Medicine at Mount Sinai. I'm joined today by Dr. Samantha Lagner, a rising third-year fellow in pediatric emergency medicine at the Mount Sinai Hospital here in New York. Together, along with the help of many experts, both locally and globally, we have developed pediatric critical care simulation curriculums in both Nepal and Botswana. And we're so excited to share our processes and lessons learned with all of you today.
Before diving in, let me outline our objectives for this session. By the end of the presentation, you will understand the background and significance of pediatric emergency training in low-resource environments, learn about the implementation and outcomes of two pediatric advanced life support training programs, the American Heart Association, or AHA, PALS program in Nepal, and the Initiative for Medical Education and Global Health, IMEGH, program in Botswana. You will also appreciate the importance of research and evaluation in improving medical education in these contexts, as well as reflect on the lessons learned, limitations, and future directions for scaling pediatric emergency training globally.
Pediatric emergency care is a critical area where timely and effective intervention can dramatically change patient outcomes. Yet, in many low and middle income countries, there are significant gaps in provider training and resources. This gap often leads to preventable morbidity and mortality among children. In response, we sought to innovate training approaches by tailoring PALS education to the realities on the ground in Nepal and Botswana. These programs emphasize hands-on skills, simulation-based learning, and local relevance, aiming to empower healthcare providers with both knowledge and confidence. Our work builds on established programs like the American Heart Association PALS course, while incorporating novel adaptations and partnerships to address regional needs.
Let me start with the Nepal program. Since 2019, the Arnhold Institute for Global Health at the Icahn School of Medicine at Mount Sinai, Dulakil Hospital in Dulakil, Nepal, and the Kathmandu University School of Medical Sciences have worked together to advance collaborative activities that improve the health and well-being of vulnerable people in Nepal and elsewhere in the world. Together, they seek to replicate the academic model of providing access to healthcare, also known as AMPATH. Dulakil Hospital, or DH, is a teaching hospital in Nepal, located approximately 30 kilometers from Kathmandu, the capital. Each month, more than 200 pediatric patients are treated in their emergency department, presenting with a wide range of acute and chronic issues, including neonatal concerns, respiratory distress, seizures, trauma, and poisonings. When compared to patients presenting to emergency departments in the United States, DH has a significantly higher acuity. There is around a 90% admission rate at DH, with more than 40% of children requiring specialized care, either in the Pediatric Intensive Care Unit, PICU, or High Dependency Unit. None of the providers at DH previously held an active PALS certification. At Dulakil Hospital, we offered healthcare providers the standard AHA PALS course, supplemented by targeted simulation training. These simulation sessions focused on high acuity, low frequency scenarios identified through a local needs assessment. In conditions like respiratory distress, status epilepticus, precipitous preterm delivery, and organophosphate poisoning. Equipment was procured through a variety of methods. Large mannequins were purchased through grant funding. Morgan was one of only 4 recipients of the AMPATH 2023 Nepal Pilot Project for our program, Global Impact, Improving Emergency Medical Preparedness and Childhood Treatments, through the Arnhold Institute, as mentioned earlier. Additional materials were donated from both the Dulakil Hospital and Mount Sinai Hospital simulation centers. As we were very tight on budget, some items, specifically fake skin, was made at home by Morgan and her family. We made sure to practice the course in cases locally with our own pediatric emergency medicine colleagues before traveling to Nepal. The PALS course was ultimately delivered at the hospital by two certified AHA instructors, me and Morgan, alongside a pediatric emergency medicine faculty member, ensuring high quality teaching. This slide outlines the steps on how we made this program come to life. A few points to highlight. We first had to become AHA PALS instructors. We were able to do this through a local instructor who is affiliated with Mount Sinai. It was a lot easier than we would have thought. As this program was being held internationally, we had to receive approval by the AHA. Luckily, our local training center was able to facilitate that communication and approval. We worked very closely with local champions at DH to determine what equipment they already had and what cases to specifically focus on. We wanted to make sure that what we taught was locally relevant. Our Nepali colleagues identified participants and helped facilitate the local day of logistics, specifically identifying the space, extra equipment, etc. We are currently in the process of developing a train the trainer instructor course. More to come on that later.
After the success of our work in Nepal, we were invited to lead a pre-conference workshop at the biannual African Conference on Emergency Medicine, held this past year in November in Gaborone, Botswana. This was a tremendous honor and opportunity. Given some of the logistical and resource challenges we experienced with the typical AHA PALS program, specifically the cost, we decided this would be an excellent moment to pilot an alternative approach. In Nepal, we were able to subsidize the participant fee, generally anywhere from $200 to $600 US, through the grant funding that Sammy mentioned earlier. But this is not always possible and can't be guaranteed in the future. Furthermore, the required equipment to stay compliant with the rigorous AHA guidelines, specifically the mannequins, feedback devices, etc., are so expensive, often costing thousands of dollars, which is prohibitive for many countries and institutions in low and middle income countries. And please let me be clear, the AHA PALS program and the other AHA certification courses are the gold standard for a reason. They offer a mixed modality of independent pre-work, didactic lectures, videos, skill sessions, and testing, both written and observed, as many of you know, since most of us have these certifications. As a PEDS EM doc, I know firsthand that the AHA PALS curriculum saves lives by preparing medical professionals on how to approach the sick or injured child. However, it is not always feasible to reproduce in a low or middle income country, and we wanted to spread this foundational knowledge with our colleagues in Botswana. We were fortunate to be connected with Dr. Eugene Tuashimi and his team at IMEGH, the Initiative for Medical Education and Global Health, which has a strong record of adapting emergency medicine training for African contexts. But let's take a moment to talk about the beautiful country of Botswana. Despite advancements in healthcare and technology, over 8 million children, approximately 60% of whom were under 5 years of age, died worldwide in 2022. Of these deaths, most were largely due to preventable and/or treatable causes. And notably, mortality rates are much higher in low and middle income countries, including many in sub-Saharan Africa. Botswana, considered a high middle income country, had an under 5 childhood mortality rate of 38.7 deaths per 1,000 live births in 2022. Despite improvement from 48 per 1,000 in 2017, there is still much work to be done to meet the Sustainable Development Goal of 25 or fewer deaths per 1,000 live births by 2030. Communicable diseases, including respiratory tract infections, diarrheal illnesses, and sepsis, remain significant contributors to this mortality rate. A child mortality audit between 2011 and 2013 revealed that 33% of all in-hospital pediatric deaths occurred within the first 24 hours, and 26% were considered avoidable. These findings suggest that there is a likely not only a delay in accessing care, but also in the identification of critical illnesses and the initiation of quality pediatric resuscitation. So, what did we do differently this time around? As I mentioned earlier, we decided to partner with Eugene and his IMEGH program. IMEGH is a Rwandan-based NGO dedicated to strengthening emergency and critical care capacity throughout Africa. Their approach focuses on adapting internationally recognized emergency training programs, such as BLS, ACLS, and PALS, to fit the reality of resource-limited settings. IMEGH courses are designed to be low cost, highly practical, and contextually relevant, making use of low fidelity simulation and emphasizing teamwork and critical reasoning. Partnering with IMGH allowed us to leverage their expertise and model for the Botswana course with a focus on scalability and sustainability. This is a screenshot from their website showing just a few of the myriad of course offerings, most of which are completely free. I encourage you all to check out their site at www.imegh.net. Using the many resources available to us, we worked closely with Eugene to augment his Developing PALS program. We created supplemental instructional videos on topics ranging from the choking infant to how to use a defibrillator to how to start an intravenous line. Each video ranges from about 30 seconds to 5 minutes and goes through the necessary equipment, setup, and how to perform the specific task. We also made PALS pocket guides, seen here on your screen, and provided these to each participant, similar to the AHA PALS card. The IMEGH PALS course was ultimately taught as a one-day pre-conference workshop that we offered twice. 36 participants attended across the 2 days, 16 on day 1 and 20 on day 2. The majority of participants were medical residents, particularly in pediatrics, about 60%, and predominantly from Botswana, about 85%. Notably, only 18% of participants had previously completed a PALS course in their training, highlighting the unmet need for pediatric emergency training in the region. The course was led by 7 instructors, 3 pediatric emergency medicine specialists, and 4 emergency medicine providers, all from Mount Sinai, all of whom had AHA PALS in provider cards, and 3 of us were AHA PALS instructors. Participants completed preparatory online materials before the course, including videos and quizzes, ensuring readiness. The workshop combined lectures, skill stations, and simulation cases, fostering active learning and teamwork. Again, here's a summary of our process. It is important to highlight the partnerships between the institutions, in this case, Mount Sinai, the University of Botswana, and IMEGH. The other point that deserves particular note is the needs assessment. We had to determine what equipment was already available at the University of Botswana and work within those constraints, especially since we didn't have the grant funding like we had in Nepal. This was best accomplished by identifying a local resident at the University of Botswana who was able to identify the simulation equipment and take pictures for us so we knew exactly what we had to work with. I just want to take a moment to level set. I've always been interested in travel. I studied abroad in undergrad and love to explore different cities and countries any opportunity I get. I'm also clearly passionate about healthcare, specifically pediatrics and critical care. However, I have no formal training in global health. I didn't even know a global health fellowship existed until I became faculty at Mount Sinai. So with that said, I jumped into both of these projects with a lot of enthusiasm and travel experience, but nothing close to structured global health training. No MPH, no MBA, you get the point. So below are a few tips that I have learned along the way, and I want to take a moment to share them with you. Number 1, find yourself a team. You cannot do any of this alone. You need to surround yourself with like-minded people who are passionate about learning, teaching, and cultural exchange. Hence my co-captain in all of this, Sammy. You need to make sure these folks are not afraid of the unknown, and better yet, welcome it, and have a soft spot for adventure. Your team is your lifeline. Number 2, do not reinvent the wheel. It's cliche, but so true. Ask mentors, subject matter experts, friends, colleagues for help. As an example, when we were working on the pilot program for Nepal, we wanted to practice the simulation cases on our own PEM division. So we reached out to Dr. Christine Saraceno, who's one of our simulation leads at Mount Sinai. Not only did she provide us with tremendous constructive criticism and feedback, but she also decided to join us in Nepal, just making our project that much stronger. Number 3, do not rely on a stable internet connection when abroad. We were fortunate to conduct both of these courses at academic teaching hospitals with reliable internet for the most part. However, we were prepared if we lost Wi-Fi. We downloaded all of our presentations and videos ahead of time and had paper copies of any printed materials such as surveys or assessments. We also had a portable projector should a high-quality TV or screen not be available. Number 4, be creative with funds. For Botswana, we, the 7 faculty, residents, fellows who traveled together, volunteered not only our time, but we had to pay our way. This is important to mention since funding is often one of the limiting factors for global health. We were creative with our CME and GME funds, and both Sammy and I took advantage of the DOCS Foundation, affiliated with Doximity, and received $2,400 US each to subsidize our flight to Botswana. It was a relatively straightforward application, and I encourage all of you to check out their website. Here's a screenshot of their webpage highlighting some of the trips that they have previously funded, including ours. Number 5, pack smart. If you are traveling with equipment, be sure to bring the appropriate documentation so that you don't run into any issues at immigration. If you're donating equipment, make sure you also supply batteries or chargers or have other ways for the local institution to keep it running and keep it clean and maintained. And number 6, seems obvious, but always worth repeating. Identify a local champion or two. You need boots on the ground, so to speak. You have to have someone to contact for questions, big and small. What equipment is available? What room do we have? And are there cultural expectations for lunch or breaks? Nepal takes their tea time very seriously. This local champion will teach you more than you would ever expect, and you'll develop a lifelong friendship along the way.
As I mentioned in the objectives section, we want to take a moment to highlight the importance of research as a means to evaluate the courses in order to improve participant experience and promote this work to encourage others to teach life-saving certification courses in other LMICs or low and middle income countries. We applied frameworks like the Kirkpatrick model to assess learning outcomes at multiple levels, from participant reaction and knowledge gain to behavior change. Both projects included pre- and post-training assessments, simulations, and surveys designed to capture learner experiences and educational outcomes. In Nepal, as this was our first pilot project, we conducted the traditional AHA PALS course and also offered supplemental simulation training designed around locally relevant emergencies. Our surveys indicated significant improvements in provider self-reported confidence and comfort with critical procedures immediately post-training, with retention noted at 3 months. The use of low fidelity mannequins proved both practical and effective in this setting. While subjective measures have limitations, these findings support simulation's role in complementing traditional didactics. The program highlighted the feasibility of delivering high-quality pediatric emergency education at a regional hospital in Nepal. Of course, there were limitations to our study. Survey-based research is inherently subject to biases such as question wording and order effects. Participation was voluntary, raising potential self-selection bias. Additionally, confidence and comfort are subjective and do not equate directly to clinical competence. While surveys were piloted, cultural and language differences may have affected responses as well. The Botswana IMEGH PALS course demonstrated strong feasibility and acceptability among the pediatric residents and other participants. Free course materials and volunteer instructors reduced barriers to access. Participant feedback emphasized the value of simulation-based learning and teamwork-focused scenarios. Although limited by sample size and scope, the study provided important insights into adapting pediatric emergency training in sub-Saharan Africa. Only a small minority had prior PALS training, underscoring the urgent need for programs like IMEGH.
Both projects reinforce the critical need for accessible, contextually appropriate pediatric emergency training in low and middle income countries. Simulation-based learning is highly valued by participants and enhances confidence in essential skills. Future efforts should emphasize objective assessment, long-term follow-up, and integration with clinical practice. Expanding training to more diverse provider groups and regions is also incredibly important. We are currently working on a train-the-trainer model for the IMEGH PALS program. Our hope is to use this as an archetype for other instructor programs that are reproducible, locally sustainable, and adaptable. In conclusion, our work in Nepal and Botswana demonstrates that tailored pediatric emergency training programs are feasible, impactful, and welcomed by learners. By combining standardized curricula with contextual adaptations and hands-on simulation, we can bridge critical gaps in pediatric emergency care. Research and continuous evaluation will guide us in refining these programs for maximal patient benefit. Before we close, we wanted to take a quick moment to thank the following people for their time, efforts, and expertise. Neither of these trips would have been possible without their support. The following 2 slides have some background information about us, as well as our emails and a list of references. Please don't hesitate to reach out with any questions, comments, or ideas for future collaboration. Thank you for your interest in global health. We hope to work together soon.